Good morning, all. Today's topic is acute ischemic stroke. So let us start with the lecture. So with all stroke, there were 13.7 million new strokes, all types, in each year. Globally, every fourth person aged over 25 years will suffer a stroke in their lifetime. Stroke is the second leading cause of death worldwide. 5.5 million people die of stroke annually. Stroke is the leading cause of serious long-term disability every year. Over the 116 million years of healthy life is lost due to the stroke. Out of all stroke, the ischemic stroke consists of 80% of total stroke and 12% are hemorrhagic in nature. In 2016, over 9.5 million new cases of ischemic stroke occurred worldwide. Strokes can happen at any age. Nearly 60% of all the new ischemic stroke happen in people younger than 70 years of age. Even 7% occur in under the 44 years of age. Each year, 52% of new ischemic stroke occur in men and 48% in the women. Annually, over 2.7 million people die from ischemic stroke. Definition: who defines stroke as or cerebrovascular accident as a rapidly developing clinical sign of focal or global disturbance of cerebral function with symptoms lasting 24 hours or longer or leading to death with no apparent cause other than the vascular in origin. Transient ischemic attack is defined as brief episode of neurological dysfunction in which signs and symptoms resolve completely after a period of 24 hours, usually within 30 minutes to 1 hour. The stroke can be classified as acute focal bloodism due to the vascular origin. The vascular system could be arterial and venous. The pathology could be infarction, which is today's topic, that is 85% are infarction and remaining 15% are hemorrhagic stroke. The site of lesion can be divided into, in ischemic stroke can be divided into anterior circulation stroke, which occur in 65% of patient, and posterior circulation which occur in remaining 20%. In hemorrhagic, it could be brain parenchyma, the percentage is 10%, and in subarachnoid space occurs in 5% of the patient. The clinical classification can be divided into total anterior circulation stroke, partial anterior circulation stroke or a lacunar stroke, and posterior circulation stroke, which account for 20% of the stroke. The common pathology which is occur in ischemic stroke are embolism. It could be cardiac or major vessel, and thrombosis in situ. And in lacunar stroke, it's a thrombosis in situ. Posterior circulation, it could be thrombosis or embolism from the cardiac source. Brain stroke, they can be again divided into ischemic and hemorrhagic. We are now dealing with the only ischemic stroke. The incidence and stroke subtypes are like, as you know, the hemorrhagic strokes constitute 15% of the stroke and remaining 85% are ischemic stroke. Out of that, atherosclerotic cerebrovascular disease could account for 20% of the risk, which include heart diseases, atherosclerotic plaque, causes clot and debris to dislodge and occlude the brain arteries. The small vessel disease lacuna constitutes 25% of the stroke patient, which is a chronic injury causes local injury to the small vessel directly in the brain. The remaining 20% are cardioembolic in origin, and clots from the heart travel to the brain to the vessels, and in case of atrial fibrillation. And 30% we cannot pinpoint the cause of a stroke, like cryptogenic. There's a lots of still don't understand about the stroke, and sometimes there could be no reason for the one. Rare causes of stroke include things like coagulation disorder and drug abuse. Risk factors for the stroke. There are non-modifiable risk factors and modifiable risk factors. Non-modifiable risk factors like age, like advanced age, in gender, male are more, male gender is a more risk factor for the stroke. Race, African American, Asians and Hispanic race are more common or a risk factor for getting stroke. Family history of stroke and low birth weight, these are the non-modifiable risk factor for the stroke. And modified factors like hypertension, the most important risk factor for the arterial stroke. Second one is atrial fibrillation, is the most important and treatable cause of cardiac stroke, ischemic stroke. Other cardiac diseases, diabetes, dyslipidemia, sickle cell anemia, asymptomatic keratostenosis, postmenopausal hormone therapy, oral contraceptives, and life factors associated with factors are cigarette smoking, alcohol, obesity, physical inactivity, and diet. So we are now getting a risk factors for ischemic stroke, like embolic stroke. The risk factors like arrhythmia, especially atrial fibrillation or flutter, artery to artery embolization. So the embolization from large artery can dislodge and get lodged into the intracranial arteries, and which can cause stroke. Bacterial endocarditis, so that the clots or embolic clots are formed in the heart in the vulnerable areas like the walls, and it can travel up to the cranial arteries and get lodged in the smaller cranial arteries, and patient can present with ischemic stroke. Bioprosthetic or mechanical heart wall, again they are high risk for getting thrombosis on the wall, which can be dislodged and can cause. Again, dilated cardiomyopathy, as there is a little movement of the myocardium and clots can be formed on that myocardium, and that can travel to up to the cranial arteries and can form this patient can have a ischemic stroke. Heart failure with ejection fraction of less than 30. The mechanism is same. Because of the poor contractility of heart, there are more chances of getting clots, which are again dislodged, and patient may present with a stroke. Myocardial infarction within the past month, patent foramen wall, rheumatic mitral and aortic wall disease. Thrombotic, it could be aortic dissection, arteritis or vasculitis, atherosclerosis, diabetes mellitus, as diabetes is more, the atherosclerosis is more in diabetic patient, the vessel wall disorder like fibromuscular dysplasia, hypercoagulable states, hyperlipidemia, hypertension, polycythemia vera, and thrombocytosis. Again, little bit of a hypercoagulable states. These are again rare causes of ischemic stroke. The inherited causes like factor related mutation, thrombin gene mutation, protein C and protein S deficiency, antithrombin 3 deficiency, hyperhomocystinemia. Acquired causes like malignancy, surgery, trauma, pregnancy, oral contraceptive pills, tamoxifen, immobilization, chronic heart failure, nephrotic syndrome, inflammatory bowel disorder, heat, myeloproliferative disorder like polycythemia vera, essential thrombocytopenia, paroxysmal nocturnal hemoglobinuria, and hyperviscosity like Waldenstrom microglobinemia, multiple myeloma, marked leukocytosis in acute leukemia, and sickle cell anemia. So pathophysiology of stroke. Whenever there is a ischemia or reduced blood flow to the reduction to the brain, there is a decrease in energy reserve, which lead to acidosis and dysfunction of sodium potassium channels, which leads to membrane depolarization, which again lead to glutamate release, which causes increase of intracellular calcium and opening of calcium channels. This leads to activation of enosynthesis, lipases, proteases, and endonucleases, which leads to production of nitrous oxygen derivatives, and which causes lipid peroxidation, protein denaturation, fragment DNA, necrolysis, apoptosis, and irreversible cellular damage. Certain time patient can have reperfusion, cytokines, and inflammation. Ischemic stroke pathophysiology. The first few hours are very important. Time is a brain, save the penumbra. So these, the red part is the ischemic zone, and what is called as the greenish yellow part, all over that reddish part is called as a penumbra. As the time passes, the ischemic zone goes on increasing, and ultimately the ischemic zone equals penumbra. So our ultimate goal is to preserve as much as penumbra as possible. So penumbra is a zone of reversible ischemia around the core, irreversible infarction, salvageable in first few hours after ischemic stroke. Penumbra damaged by hypoperfusion, hyperglycemia, fever, seizures. So we need to avoid this condition, which will again damage the penumbra, like hypoperfusion, hyperglycemia, hyperpyrexia, that is fever, and seizures. So little bit about the anatomy of the circle of, as you all know, circle of Willis, we have two vertebrae artery, which right and left vertebrae which joins to form basal artery. Then we have posterior cerebral artery, and we have posterior communication artery, which joins posterior cerebral artery to the middle cerebral artery, and anterocommunicating artery will join with the anterocerebral artery. So whole these arteries form the circle of Willis, which supplies the brain. So as you know, there are frontal lobe, temporal lobe, parietal lobe, and occipital lobe, four lobes in the cerebral hemisphere. Then we have cerebellum and spinal cord and brainstem. So let us have some brain function by lobe. As you know, different lobe of cerebrum cause different functions. Like for frontal lobe is involving problem solving, judgment, inhibition, personality, emotional trait, language production, motor planning. The temporal lobe is involved in understanding of language, organization, and sequencing, information retrieval, music awareness, memory, hearing, learning, and feeling. Parietal lobe is involved in sense of touch, taste, smell, spatial perception, visual perception, academic skills, maths calculation, reading, and writing. Occipital lobe is involved in mainly in visual perception, visual interpretation, and reading. And cerebellum, as you know, is involved in coordination and balance and equilibrium. The brain sense function helps in sense of balance, reflexes, breathing, digestion, swallowing, consciousness, alertness, and temperature. So potential impairment of stroke according to the brain, as frontal lobe, whenever there is involvement of frontal lobe, we have a loss of simple movement of body parts, loss of sequencing, loss of spontaneously in interaction, loss of flexibility in thinking. There is a patient can present with a Broca's aphasia, persistence of single thought, inability to focus on single task, mood changes and social behavioral changes, problem solving difficulties and changes in personality. The temporal involvement presents with Wernicke's aphasia, that is sensory aphasia, disturbance of selective attendance, proproxenoglosia, difficulty in identifying the naming object, increased aggressiveness and behavior, and persistent talking. Short and long-term memory loss, hypersexuality, difficult categorizing object. Parietal lobe involvement present with anomia, agraphia, alexia, dyscalculia, and apraxia. Inability to attend more than one object at a time, difficulty in drawing object, inability to focus on visual attention, difficulty with hand and eye coordination, difficulty distribution left and right. Occipital lobe involvement occurs and patient present with color and movement agnosia, difficulty reading and writing, defect in field of vision, difficulty in locating object, hallucination, inability to seeing object, inability to recognize a word, and difficulty in recognizing a drawn object. The brainstem involvement causes dysphagia, vertigo, insomnia, sleep apnea, difficulty in organizing and understanding the environment, inability to balance and coordinate movement. The involvement of cerebrum can cause tremors and vertigo, inability to coordinate fine movements and walk, inability to reach out and grab the object, slurred speech, and inability to make rapid movement. So these are the different stroke syndrome depending upon the involvement of branch. The MCA or branch of MCA occlusion can present with contralateral lower facial hemiplegia or contralateral hemiplegia, that is involvement of arm and leg, and contralateral sensory loss of face, arm, and leg. The contralateral homonymous seminopia, dysphagia, and contralateral neglect, that is non-dominant hemisphere. AC occlusion can present with contralateral hemiplegia. The leg involvement is more than the arm, and contralateral sensory loss. The leg is more involved than the arm, and patient can have apraxia. The posterior circulation and vertebrovascular system occlusion, patient can present with many syndrome depending upon the location of occlusion. We will come to this syndrome on the next slides. The posterior circulation, cerebral occlusion can present with contralateral homonymous seminopia, sensory impairment, and involuntary movement. So these are the different strokes depending upon the level of stroke at the brainstem. So at the level of medulla, we can have two syndrome. The first is middle medullary syndrome and second is lateral medullary syndrome. In middle medullary syndrome, the vessel occluded is usually vertebral artery, the branch of vertebral or lower basilar artery. The side of lesion is the same. When there is involvement of same side lesion, the patient have ipsilateral 12th nerve palsy and paralysis and atrophy of left half of the tongue. When there is opposite side lesion, patient can have a contralateral pyramidal tract and middle lemniscus involvement, resulting in paralysis of arm and leg, sparing face, impairment of tactile and proprioceptive sense over the half of the body. And in lateral medullary syndrome, the vessel occluded will be vertebral artery, posterior inferior cerebral artery, superior middle or inferior lateral medullary arteries. The side of a lesion will be same side. The structure involved are descending tract of 9, nucleus fifth of the nerve. The patient can have pain, numbness, impaired sensation over 1.5 of the face. Fontaine syndrome, these are three syndromes, Miller-Gubler, Fowell and Reynolds. In Miller-Gubler, site of lesion is always pons, structure involved are facial nerve nucleus and corticospinal tract. Patient present with ipsilateral facial nerve palsy and contralateral hemiparesis, usually vascular in nature. In Fowell syndrome, site is again pons. It involves facial nerve nucleus, corticospinal tract, and lateral gaze center. So patient can have lateral facial nerve, ipsilateral facial nerve palsy, contralateral hemiparesis, same as a Miller-Gubler. Only patient again in addition have horizontal gaze palsy, and usually it's vascular in nature. So Miller-Gubler plus lateral gaze palsy is Fowell syndrome. In Raymond syndrome, again site is pons. Structure involved are 6 cranial nerve, that is abducent nerve and corticospinal tract, and patient have ipsilateral 6 nerve palsy along with contralateral hemiparesis, and usually it's vascular in origin. The midbone syndrome can be classified into 5 types like Weber's, Claude's, Benedict's, North Angle and Perinaud syndrome. The site is in Weber syndrome, site is base of the brain, cranial nerve involved are third, and tracts involved a corticospinal tract, and patient present with oculomotor palsy with cross hemiplegia. In Claude's syndrome, the site is tegmentum of midbrain, the cranial nerve involved again third, and tracts involved are red nucleus and brachium conjunctum. The oculomotor present with oculomotor palsy with contralateral cerebral ataxia and tremor. In Benedict syndrome, the site is again tegmentum of midbrain, the cranial nerve involved is third, and the tracts involved are red nucleus, corticospinal, and brachium conjunctum. The oculomotor palsy with contralateral cerebral ataxia, tremor, and corticospinal signs. In North Angle, the site involved is tectum of midbrain. Patient can have unilateral or bilateral third nerve palsy. The tracts involved are superior cerebral peduncles, and patient present with ocular palsies, paralysis of gaze, and cerebral ataxia. In Perinaud syndrome, the site is dorsal of midbrain. The tracts involved are supranuclear mechanism for upward gaze and other structures in periaquilatory gray matter. The paralysis of upward gaze and accommodation and fixed pupil are the signs of Perinaud syndrome. Cerebral stroke, the territory, whenever there is involvement of superior cerebral artery, the signs are ipsilateral limb and gait ataxia. The structure involved are midbrain, thalamus and occipital lobe, and the signs are top of the basilar syndrome. Whenever there is involvement of posterior inferior cerebral artery, the signs and symptoms are ipsilateral limb gait and ataxia. The structure involved are dorsolateral medulla and patient present with the Wellenberg syndrome. Anterior and anterior inferior cerebral artery, patient have vertigo and ipsilateral deafness. The structure involved are lateral pons, and patient have contralateral facial weakness, numbness, and hearing loss. So in evaluation of stroke, we have to determine if the symptoms are due to stroke, localize the brain region, establish the type of stroke, ascertain the likely cause. In clinical assessment, history, general examination, and neurological examination remains the cornerstone of evaluation. The use of stroke rating scale, preferably NHS scale, and recommended. It has been recommended that patient with acute stroke less than 7 days of progressive stroke should be admitted. Diagnosis of stroke can be made with the help of a CT scan or MRI scan, and CT scan is a standard for evaluation of acute stroke to rule out other conditions such as tumor, abscess, hemorrhage, and other brain lesion. MRI scan allows for better evaluation of course of acute treatment, identifies the infarction, and rule out other condition, late hemorrhage. Cerebral angiography can be done, which shows the blood vessels and it provides visualization of vascular system. So these are the different types of stroke, how the intercirculation stroke depending on the vessel involved. Whenever there is a involvement of cortical, it involves the frontal, temporal, and some part temporal part of the midbrain along with the thalamus. In proximal AC occlusion, patient can have only middle part of frontal and certain part of the thalamus. In proximal M1 occlusion, patient can spare some part of the frontal lobe and involve remaining part along with the thalamus. And in distal M1 occlusion, the thalamus is spared. In M2 branch occlusion, inferior branch, the frontal, majority frontal and thalamus part is spared. And in M2 occlusion superior branch, the mostly the occipital or temporal part is spared along with the thalamus. In lenticular infarction, we get a smaller infarct in the thalamus, and striatocapsular infarction, we typically get a small infarct in the capsule, internal capsule. This slide showing the acute infarct on MRI. So, infarcted zone we can make out. It is just whitish or radio opaque shadows in one neuron, and it again shows a whitish zone of infarction on MRI. So stroke is when we have a acute neurological deficit, stroke is suspect. Initial neuroimaging to rule out hemorrhage. So if it is within 6 hours or say 4.25 hours, we can thrombolize the patient with TPA, and whenever there is a we can go for angiography, and if there is a acute thrombosis, critical thrombosis there, we can go for mechanical thrombectomy. Whenever the patient present between 6 to 24 hours, CT or angiography perfusion can be done. Mechanical thrombectomy can be done if permitted. And when patient present more than 24 hours, we can give a standard care depending upon the stroke etiology. So, stroke algorithm for stroke and TIA management. When we suspect stroke or TIA, we have to go through the ABCs of then we check glucose because hypoglycemia can mimic stroke. Then we have to obtain imaging. If there is ischemic stroke, we can consider for thrombolysis or thrombectomy. Whenever patient establishes the cause like atrial fibrillation, we can consider warfarin and treatment of atrial fibrillation. Whenever there is a carotid disease, we can consider for angiography and stent, or in other condition, we can treat the specific cause. So just little bit about the eligibility criteria and exclusion criteria for the intravenous thrombolysis. The eligibility criteria, it can be initially it was 0 to 3 hours, but can be extended to 3 to 44 hours. For 0 to 3, age must be more than 18. Acute onset stroke symptom, severe, moderate or mild but disabling. In 3 to 4 hours, age should be less than 80 years. No stroke, both diabetes, mellitus and post stroke. NIH score should be less than 25, not taking any oral anticoagulation agent. The exclusion criteria should be intracranial hemorrhage, CT evidence of obvious hypodensity, ischemic stroke within prior 3 months, severe head trauma within 3 months, intracranial or spinal surgery within 3 months. Symptoms suggest of subarachnoid hemorrhage, gastrointestinal bleeding within 20 days of stroke event, platelet counts less than 1 lakh, INR more than 1.7, APTT more than 40 seconds, and PT more than 15 seconds. Treatment dose of global COVID heparin within 24 hours, warfarin use of with INR more than 6. Drug and anticoagulation drug use. There is clinical suspicion of infective endocarditis, known suspect aortic arch dissection, intraaxial or intracranial immunoplasm, giant unruptured or unsecured aneurysm, and high burden of cerebral microbleed more than 10 demonstrated on MRI. So drugs which can be used for thrombolysis are clinic place. Usually single IV dose is given bolus. Whenever the age was weight was less than 60, we can give a dose of 30. Less than 6, weight between 60 to 69, we can give 30, 35. Less between 70 to 79, we can give 40. Retiplase 10 plus 10, that is 20. Over 2 minutes, 20 minutes apart. Altiplase can be given as 15 mg of IV bolus, then 0.75 mg per kg over 30 minutes and 0.5 mg over 60 minutes. Antiplatelet and statin use are aspirin, clopidogrel, and anticoagulation with the enoxaparin or ultra fractionated heparin. Complication stroke like brain edema, hydrocephalus, elevated intracranial pressure, seizures, hemorrhage transformation, recurrent hemorrhage, acute delirium, recurrent stroke, depression, aspiration, atelectasis, pneumonia, AMI, chronic heart failure, DVT, pulmonary embolism. Patient can have cardiac arrhythmias, hypertension, stress ulcers, GI bleed, constipation, dehydration, electrolyte imbalance, malnutrition, hyperglycemia, urinary incontinence, UTI, pressure ulcer, contractures, and falls with or without fractures. And the last, we should have a stroke rehabilitation, prevent, recognize, and manage comorbid medical condition along with the stroke, maximize functional independence with the physiotherapy, optimize psychosocial adaptation patient and the families, and facilitate the resumption of prior life roles and community reintegration, and enhance the quality of life. So that is for today. This is the end of lecture.